Hello, my name is Catherine Ferrier. I'm a physician in the Division of Geriatric Medicine at the McGill University Health Centre. I'm going to talk to you today about advanced care planning. This is a concept I'm sure you're all familiar with. Our objective is to help to explain and apply principles of end-of-life decision-making and to engage with patients to facilitate advanced care planning and goals of care decisions. I have no conflict of interest. So why talk about this? As we all know, high technology care is not necessarily better care. People with serious illness often receive interventions that are not aligned with their goals, and those who participate in conversations about these issues often receive the care they choose and have better quality of life. So looking from a Christian perspective, the next few slides are from the Catholic tradition, but I suspect that they are acceptable to all of us. So the notion that the human life is the basis of all goods. If you're not alive, you can't benefit from any other good or any other right. All human lives have equal value. We are stewards, not owners of our life, which is in contrast with current thinking in secular circles. But that the means to conserve our life are not always obligatory, but can be abandoned in certain cases because of the nature of those means, whether they're physically or morally impossible, or for some other reason. But we're always looking at the nature of the means being used and not living with the illness of the condition. So not refusing care because of a disability that we have or that we expect to have, but because as we all see, the intervention is out of proportion with the benefit that we expect. So this is from a 40-year-old document from the Catholic Magisterium that observes that we can make a correct judgment on the means by studying the type of treatment used, its complexity or risks, its cost, the availability, and comparing this with the result that can be expected, taking into account the state of the sick person and his or her physical and moral resources. So in a graphic representation, it can be ethical to refuse a treatment if the burdens outweigh the benefits. Burdens could be risks related to the treatment, pain or discomfort related to the treatment, its interference with our life as we are living it, our relationships and so on, or any repugnance that we might have to that kind of treatment. Again, this is from John Paul II, who looks specifically at nutrition and hydration and says essentially that in principle, it is not a medical treatment. It is part of the normal care due to a patient, the normal means of preserving life, and as such is morally obligatory, but then says insofar as and until it is seen to have attained its proper finality. That means that it does not always attain its proper finality. For example, people whose death is imminent may in fact feel worse if food or liquid is given to them or forced upon them, and that changes the moral status of this intervention. So this I saw in a blog, on the CMAJ blog a couple of years ago, a quick case that we'll come back to. So in 88, it was written by the family medicine resident who was the granddaughter of this patient. So she was 88 years old, admitted for an MI, had class 3 heart failure, worsening kidney disease, and diabetes. So the hospital called the family early in the morning about code status, but the patient had already stated her preference. She wanted full code, full treatment, and she was competent to decide. So they went ahead and treated her. Her course was very complex with a pacemaker, dialysis, many other interventions, and no one after that first day tried to explore her understanding of her conditions or her options. There was no palliative care consult, and she died 5 weeks later, shortly after being offered a colonoscopy. So what are the types of conversations we might have to prevent an undiscussed course of illness at the end of life? So there are 2 different types timing-wise. The first is what we really call advanced care planning, which is when the patient is medically stable, perhaps in the family doctor's office, in the specialist's office, or at home, especially if they're over a certain age, have a serious chronic condition or a new serious diagnosis. And then goals of care discussion, which is much more focused. There's something happening. Patients admitted to hospital or to long-term care because there was some change in their condition. The surprise question that you're probably familiar with, would I be surprised if this patient was dead in 1 year? And then we can review the goals of care whenever the patient's condition takes a turn or when the patient requests it. So stepping back a minute, let's look at informed consent. So we know these principles that for consent to be valid, it has to be voluntary, the patient has to be capable of making the decision, and the patient has to be properly informed. That is basic medical ethics. But for consent to be informed, the patient has to receive and understand detailed information on their diagnosis, including any uncertainty, possible other diagnoses, the nature and purpose of the proposed investigations or treatments, their chances of success, alternatives, and the consequences of doing nothing. So the question becomes obvious: how can consent be informed in advance of the situation that requires a decision? So there are certain things we know and certain things that we don't know. We know the patient's present age, their medical diagnoses, their degree of frailty, which we'll come to in a moment. We know what medical science says about prognosis given this information. There are calculators, for example, and I'll mention one or two. And we know the expected benefits and risks overall of the interventions that might be needed in the future for this patient. But what we don't know is what will happen to this patient, what medical events might occur to them, and also how their goals will evolve as their medical condition changes, which happens with everyone virtually. Prognostic indicators, this is one from the JAMA 20 years ago that scores different questions, ADL dependencies, comorbid conditions, certain lab values, and comes up with a score. This is the survival, depending on whether you have 0 to 1, 2 to 3, or more points on this scale. So you can see that it does have some prognostic validity. This is a site called Eprognosis, which is very interesting, has a number of different calculators, and you can look at it if you like. It also talks about communicating prognosis, which is very interesting with videos and about different communication skills that we'll get back to. So what is frailty? This is something we talk about a lot in geriatrics. It's a state of vulnerability to poor recovery after a stressor event. So in the pictures, the picture on the left is my mother a couple of weeks before her 90th birthday after a tennis game. She is not frail despite her age. The others are typically frail patients. So people of the same age might vary a lot in their vulnerability to poor outcomes, whether it be death, institutionalization, or any other unfavorable response to medical and surgical interventions. And it's a consequence of cumulative decline in many physiologic systems during a lifetime. So in a frail patient, an apparently small event, a new drug, a minor infection, or minor surgery can result in a disproportionate change in their health state, from independent to dependent, from mobile to immobile, perhaps becoming prone to falling, becoming delirious. So a treatment that would be beneficial in a more robust older person might cause harm to someone who is more frail. Typically, tight control of blood pressure or blood sugar could lead to falls, for example. A hospitalization or an ICU stay could lead to delirium, multiple medical complications that we would not expect in a less frail person. This is a scale that you might be familiar with. There are many, many ways of measuring frailty, which proves that there's no one perfect way. Some look at lab values, some look at diagnoses. This looks at a level of autonomy, which doesn't mean that frailty and level of autonomy are the same thing, but level of autonomy often reflects frailty. So you go from very fit to terminally ill with everything in between. This is visually easy to apply. There's a clinic at Dalhousie University, some of you might be familiar with, called the PATH Clinic, Palliative and Therapeutic Harmonization. So what they're trying to do is to use frailty and measurements of frailty to help people to make good healthcare decisions, and knowing that they might not respond the same way to any illness or treatment than somebody who's less frail. And if we don't align expectations with prognosis, people could make decisions that don't really have anything to do with what's likely to happen to them. And so it's important that they understand their condition, their level of frailty, to make good medical decisions, whether it's in advance or in the act. And the notion that decision-making is dynamic. Without proper context, advanced care planning can lead people in the wrong direction. So they try to help people learn which decisions can be made in advance, which ones can't, and empowering the patient with the skills and knowledge necessary to make good medical decisions. So getting back to advanced care planning, it has to be done with caution. We can't decide everything. We can't map out a menu of our future medical care, although some people try to do that. We need to inform the patient about their current medical condition, their prognosis, and their degree of frailty. We cannot inform them, as we said, in detail about possible future medical conditions requiring decisions, but we can discuss general directions, preferred level of care. We're trying to guide the patient to name a substitute decision maker. That is the key element. Make sure the substitute decision maker is informed about the patient's condition, their outlook on medical care, and empowered to make decisions in the moment based on what they have learned about the patient's goals, their background medical conditions and degree of frailty, and then the information and advice of the healthcare team in the act when the event happens and when the decision needs to be made. So we try to minimize instructions on specific treatments and maximize choosing and preparing a substitute decision maker. There are commonly used texts. I'm going to give you an example from Quebec, from what we call a mandate, which is a document that names a person to decide about all kinds of decisions in case of loss of decision-making capacity. There are probably other examples in other provinces. Problems include ambiguous terminology, openness to interpretation, depending on the views and perspective of the person reading them. They're out of context, as we've discussed, and often drawn up by legal professionals without any discussion with a health professional. So I really wonder, I see these documents shown to me by my patients, do they have any idea what they're asking for? This is one I've seen several times. So the mandatory, read power of attorney or whatever other term it might be in your province, could make all decisions, taking into account the following, that I'm opposed to heroic, diagnostic, and therapeutic measures. So what is heroic? That is a very dramatic but general term, and we don't know what that necessarily means. Superfluous given my condition, does that clarify what heroic means? Perhaps to a certain extent, but not necessarily to the doctor in the emergency room who's reading this and does not have any past knowledge of the patient's condition or values or preferences. Goes on to saying they don't want treatments that would increase or prolong suffering needlessly. Sometimes we need painful interventions to save our life or to improve our health, and whether we choose to have them or not depends on many factors that again are not known to somebody who's reading this document. And lastly, I'm opposed to any intervention that could cause serious after effects or leave me in a vegetative state. So obviously, no doctor is going to advise an intervention that is probably going to cause serious after effects. Every intervention can possibly cause serious after effects. We're looking at the proportion of the risks to the benefits, and so this sentence is meaningless basically, but is thought to have a lot of meaning sometimes by people who read it. So getting back to the conversation, we have to ensure that we have enough time to talk with the patient. Maybe if it's in an office, make a special appointment for that purpose with the patient and perhaps the person they're thinking of designating as their substitute decision maker. Could be done over several visits in bits and pieces, but offer some information in advance on what this meeting is going to be about, so the patient can do some preparing. So we'll talk about their health conditions, so their age, the diagnoses they have, their degree of frailty, and any prognostic or life expectancy information we can give them in that context. We can see what they understand of that. We can see their personal situation and how that applies to any medical decisions they might have to make. any prior reflection on goals of care, and discuss the importance of choosing a substitute decision maker in case they cannot decide for themselves. Discuss the importance of reflecting in advance on certain possible care needs and choices and making sure the substitute decision maker is aware of them. Explain the small number of technological interventions that might be offered and that need to be decided in advance. You can't stop and reflect when someone is in cardiac arrest and needs CPR. We have to have thought about that ahead of time. Mechanical ventilation, you do have a little bit more time perhaps, but it's good to have thought about. And offer information on the expected benefits and burdens of such interventions in the patient's specific health condition at the time of the conversation. So what decisions can be made by the patient at this meeting? The choice of the substitute decision maker, the conversation that they are having at that moment or will have in the future with the substitute decision maker, general preferences, perhaps ICU versus no ICU, not in a young, healthy person, but in someone who's old and frail and does not expect benefit from serious enough illness that would require ICU. Home versus hospital for someone who's even farther advanced on the frailty scale. The few specific decisions that might need to be made in advance, as we've discussed, especially CPR and mechanical ventilation. This is a website that is very useful. It has its limits. There is some reference to refusing care because you're too disabled to enjoy life, which I'm not crazy about, but it has a lot of good information and a lot of good algorithms and even a video about CPR and many, many other things that could be useful to both health professionals and patients. It also has a page explaining the legal documents that are used in each province to name a substitute decision maker. I know the picture's too small to see, but you can find this page and look up your own province if you're interested in knowing that. So clauses that could be included in a document that names the substitute decision maker explicitly authorize them to make decisions, perhaps include acceptance or refusal of an attempt of CPR, perhaps include a desire to receive food and fluids as long as they are beneficial, especially considering that is often withdrawn as a way of hastening death when the quality of life is not seen as being high enough in our culture. And perhaps an explicit refusal of medical assistance in dying, just to be sure that is very clear. How does one choose a substitute decision maker? It's obviously up to the patient, but they might reflect on finding someone that they trust, obviously, who would have the skills to communicate with the healthcare team, who's not too afraid or shy of talking to health professionals, who's able to make decisions under stress, and who would be available, not in another country, or not unavailable for any other reason. Now we're going to move on to the notion of goal concordant care, which will lead us into goals of care discussions. So, as I have alluded to, medical goals change over time as one health status changes. When we're 25 or 50 and healthy, our goals of care are generally to try anything that might keep us alive, unless there's a clear reason not to. As we become more frail, as we accumulate comorbidities, those goals might change, and naturally to the patient, but also with understanding of their condition. And that's why I don't like checklist advanced care plans. That's why you can't express a specific wish about a specific treatment and expect it to be applicable for the rest of your life. It just doesn't make sense. That's why it's important to, from our point of view, to perceive the patient's needs over time, their medical conditions, which might change the risk of the interventions, what gives them comfort, what distresses them, ask them or observe if we know them well, as we do sometimes with long-term patients, and the importance of giving authority to substitute decision makers to decide in the moment. So with whom might we want to have a goals of care discussion? People who are starting to be at increased risk of dying, new serious diagnosis in the hospital and long-term care, or the surprise question, as we mentioned before. and what might we talk about? So now the difference between the advanced care plan and the goals of care discussion is that now something is happening. There's been an acute illness. There's been a change of status requiring the move to the nursing home. And so now we have more information, and the patient is in the situation a little bit more than they were previously. So we can talk to them about their current diagnoses, their current prognosis, their current degree of frailty, and that's much more applicable to the decisions that they need to make now. Explore their understanding, ensure that they do understand. If not, start again, and choosing our language well, and so on. Finding out their prior reflection. Do they have a written advanced care plan? Have they discussed their thoughts about care with their substitute decision maker, with you, with any other health professional? Is that information available to you? And then the treatment options that are available to them being considered, and their expected risks and burdens and benefits here and now for this patient with this condition in these circumstances. Give advice. Sometimes we hear of doctors just giving sort of a list of choices and expecting the patient to choose one. That's not what we were trained for. We were trained to consider, to make a decision about what is the best option and to propose that to the patient, while at the same time leaving the patient free to make their own decisions, and to reach together a plan on goals of care. So how do we begin this conversation? It's not always easy. Patients are not always ready for that. So we have to plan a little bit in advance, especially if we're not used to doing it. Maybe have a script, have a few lines that we have planned ahead of time to start the discussion with the patient. So maybe having given the diagnostic information, the prognostic information, the obvious treatment proposals, there's something else I wanted to discuss. For example, step back and try to look at the big picture with the patient. I have this conversation with all my patients. In other words, I'm not telling you this because I expect you to die today, but because I think this is important for anyone with a serious illness, as you now have, or at the age that you are now, or whatever. If it's a patient new to you, you're in a hospital, we've just met, but it's important to have this conversation now so we don't have to decide if there's a crisis. We're not expecting a crisis, but we want to be prepared ahead of time, and so on. So we're trying to make sure we don't alarm the patient by initiating this conversation. So how can we facilitate effective decision making, normalize the conversation, as we just discussed, take the time needed to explain, clarify, answer questions, give the patient time to assimilate the information and to reflect, might require more than one meeting, use appropriate language that they can understand, make sure they understand the options, give examples, and make it clear that you will always care for the patient even if they decide to renounce certain possible interventions. What obstacles might there be in yourself first? Lack of time, fear of causing anxiety to the patient or the family, delaying it until a moment of crisis when you can't have that calm conversation that you're open for, only initiating the conversation if you think some treatment is contraindicated, whether it's CPR or something else, the quality of the conversation, explaining in a way that the patient does not understand, or your own lack of knowledge or information to be able to provide to the patient. Obstacles on the patient and family side, maybe they've never thought of these questions, they're still in cure and getting back to my normal life mode. Maybe they're too sick, maybe they're not willing to kind of switch gears and have this kind of conversation. Maybe they have documents that are not clear. Maybe the substitute decision maker is not available, is unaware of the patient's wishes, or is not interested or doesn't understand the issues. This is a tool that can be helpful in having this kind of conversation. It's called the Serious Illness Conversation Guide. Again, I know you can't see the small print, but you can look up Ariadne Labs Serious Illness Care and find this. This is the second page. This is going back to Eprognosis that I mentioned before. So they have sections on all the different communication skills that we might need to have good goals of care conversations, addressing emotions, which are always present in conversations of this type, discussing diagnosis, prognosis, asking the patient's permission to talk about this, discussing next steps. You can look at these and they're all backed up by videos giving you examples of people having this type of conversation. So in summary, as we said at the beginning, Christian principles include that although we're stewards and called to care for our own lives, the means to conserve our life can sometimes be abandoned because of the nature of those means, because they're too burdensome in proportion to the benefit expected. It is important to discuss levels of intervention ahead of time with any patient who is at risk of serious illness or death. It's important that we provide adequate medical information, not just go in and ask for a decision without having given the patient adequate information, so that we are facilitating informed decision-making as well as possible. Discuss patient values and preferences. Expect their goals of care to evolve, so to be something that we have to keep coming back to over time as their condition changes. Facilitate the decision process by normalizing it, by having a script, and by ensuring the patient that they will always be cared for. So getting back to the resident's grandmother, so at 88, many comorbidities before the myocardial infarction. Patient wants full code. One guesses that perhaps the question of code had never been discussed with the patient. It doesn't say that, but perhaps it had never had. So the patient who was living at home with her comorbidities before the acute event had perhaps not considered her mortality being imminent, and had not thought about limiting care. Since the patient is competent to decide, her wishes were respected, which is as it should be. But then what? What happens? It didn't sound from this case report that there was an arrest, but it was, of course, important to know what to do if there was one. So the patient's admitted, the patient's perhaps put in ICU, and starts having the treatments indicated for each of her organ failures, whether it's her heart rate, her renal function, and things keep happening and things keep being done in response to the things happening. But nobody seems to have stepped back and explained to the patient that she was not doing well. Why the pacemaker is not just about her heart, but it has to do with her whole condition. The same with dialysis, the same with every other intervention that's being suggested. It's not enough to talk about the risks and benefits of this treatment. You have to put it into the context, and nobody did that. Palliative care was not involved. It doesn't have to be palliative care. It can be the family doctor, the internist, the cardiologist. Anybody can step back if they're well prepared and have this kind of goals of care conversation with this patient. It was not done, and the patient died while still being in acute treatment mode, as opposed to preparing for a peaceful death mode. You've probably seen many cases like this. This patient was denied a dignified death in the true sense of the word. So hopefully we can do better. Thank you very much, and I'll be available for questions and discussion.